All Context and Care in Mental Health. April 9th, the Chicago School of Professional Psychology, February 12th, 2018. The full scope of challenges and opportunities of implementing mental health services in low and middle income communities is still unknown, according to Hanlon et al., 2014. In April 2015, a 7.8 magnitude earthquake devastated areas of Nepal. Mobile health clinics struggled to provide effective support. Integrated systems for mental health treatment were left to provide continued treatment and support. Examining current research that acts to inform these systems is crucial. Hanlon and colleagues set out to compare baseline contextual factors, challenges, and opportunities in 5 low and middle income countries in regards to implementing integrated mental health care. Utilizing large pools of public domain data, census and existing, a situational analysis tool examined cross-sectional information between Ethiopia, India, Nepal, South Africa, and Uganda. The following presentation will discuss important key aspects of cultural contextual factors related to providing integrated mental health care in Nepal. The first is demographic and public health factors. In a district, Chetwan in Nepal, with a population of 575,058 citizens, 73% were considered rural. The ethnic, linguistic, and diversity, as you note on the chart, was not great, but literacy was at about 70%, and many households, at 69%, still lacked electricity. And households with functioning latrines was only at 80%. And a basic need, clean water supply, was at 86%. Top reasons for outpatient visits included impetigo, boils, respiratory tract infections, falls injuries, and otitis media. All of these public health factors greatly influence mental health, the ability to provide mental health services in certain areas. Now, if we look at general and primary health care contexts for integrating mental health, we see a lack of healthcare facilities in Nepal. We see that there's only 2 hospitals, there's 0 community health centers, only 4 primary care clinics, 0 sub-health centers, and health posts were at 5. And the sub-health posts, usually including volunteers, there's only about 41 in the region. So as we continue to look down, we see a real lack of expert-based doctors, psychologists, counselors, and social workers. None were noted in the area. Non-physician clinical officers were present, and also nurses. As far as access to psychotropic medications, antipsychotics, antidepressants, and mood stabilizers were not available, whereas other medications, usually for treating anxiety like diazepam and phenytoin, were. So there's some discrepancy in what medications are available, and certainly limited access to experts. Now, baseline mental health care provided in the district. Here we see specialist mental health services were also few. Inpatient mental health facilities in general hospitals, there was 5 beds that were public, 25 NGO, and 48 private. Now, outpatient mental health facilities, there was none that were public. And yes, there were private and NGO noted. Psychological therapies were very limited to private hospitals, including group therapy and motivational interviewing, and there were really no other modalities that were noted as prevalent. Alcohol detoxification, there were 2 hospital bed facilities. No mental health rehabilitation, which presents a question of once a Nepali citizen impacted with mental health gets the acute treatment they need, where do they go to rehabilitate? and transition back into their life. Psychiatrists, 2 public, 3 private. There were 0 neurologists, which is also a concern in the sense that if some underlying neurological issues are noted, who's going to do the assessment and help with treatment planning and service delivery. Psychiatric nurses, there was only 1 private noted, 0 clinical psychologists, 7 private counselors, and there were 0 mental health, social workers, occupational therapists, and 0 supports noted. So we see, basic baseline mental health care in Nepal is really struggling here. Community engagement and care for scaling up mental health care. There's some interesting data noted by Hanlon et al. 2014, where community-based workers were often not paid, and volunteers were present 1 to about 1,000 citizens. There was also no links between healthcare and traditional religious healers, and no formal support for families. It was noted that psychosis was high, depression was low, and as we recall, antipsychotics were not found on the previous slide, so that's concerning. Alcohol use disorders were low, epilepsy high, and stigma is high. And abuse was also noted to be prevalent in 2 forms, chaining in homes and stones thrown. So where are the trauma-focused treatments for these citizens? Where is the outreach and the campaigns to reduce stigma in the area? These are all important things to consider when doing integrated mental health care. And the last 3, as far as community resources, peer support, self-help groups, supported housing, community-based rehabilitation, all were not noted. So these are some real concerns for Nepal. It's considered a low-income country with fragile mental health infrastructure. The contextual factors can present challenges for integrated mental health services to prosper. Deficient systems, feasibility, availability of services and professionals are central issues. Essential to sustainability of mental health integrative plans is underlying structure. This is key for sustaining quality mental health care. NGOs like the Center for Mental Health and Counseling in Nepal, which focus on psychosocial training, service delivery, school-based and outpatient interventions, may be the key. This includes access to experts with cultural contextual knowledge. Thank you for listening.